So I'm Dr. Rajesh, and I welcome you all for this medical law and ethics session. It's a great pleasure to have you all here in this session with all those questions and queries. I hope we'll clear most of your doubts in this specific time. Now, I also welcome our panel members, Professor Nandimath, Professor, National Law School of India, Bangalore. He has a 20 years of teaching experience in medical law and ethics. I also welcome Mrs. Ujjvala, CEO of Aveksha Hospital. She is an advocate and her field of interest is medical law and ethics again. Also welcome Dr. Raja Kemani, CEO and Chairman of Critical Care, Pulmonology and Sleep Medicine at Nayati Multispecialty Hospital. Sir has also been a former president of the Indian Society of Critical Care Medicine and a chairman of Ethics Committee that formulated the guidelines on end of life and palliative care. So we are very privileged to have you all here. So we'll start the session. I think we have a good number of participants. So yeah, we'll start a session. Can you
Sure. Thank you so much, Dr. Rajesh, for the introduction. I must say that I feel very privileged to be here today, to be part of this panel. I remember sitting many years ago in actually one of Professor Nandimath's classes, and I've been his student. So it's a real honor to be here today. So welcome everyone for today's conversation on medical law and ethics. I think it's overwhelming to see the number of questions that have come in from everyone, and some very, very thought-provoking questions. The format that we've decided to take for today is more conversational and not any slides or pre-existing template of what we're going to say. But keep it fairly more loose flowing, free flowing, and we have compiled your questions and put them into relevant buckets and topics that kind of make a coherent flow. And we will still open up to questions as and when people put them up in the chat box, and we'll try and plug them into where it makes sense and when we can actually so that there's a certain flow to the entire conversation. Yes, so let's get started, Professor Nandimath, by actually talking about, there was a couple of landmark cases that changed the entire course of how the medical law is perceived, viewed, how doctors are viewed, and I can definitely say it's a very clear before and after, right? And I'd love for you to speak a little bit about this to start with.
Thank you, Dr. Ujjvala. And I also equally feel privileged, let me say, to be amidst a couple of stalwarts in this particular field, starting with Dr. Rajamani. You are also no lesser a stalwart, although you technically recognized to be my student some ancient times. So I really feel elated, and what a better, sort of thing than starting from VP Shanta's judgment, which was rendered by the Supreme Court in India in the year 1995. See, I would say the prime question that was raised for the Supreme Court to answer in this particular case was whether doctors fall under the ambit of Consumer Protection Act or not. In other words, for some of our audience who may find it very technical, I would simplify. Whether can we sue the doctor in a so-called consumer court or consumer commissions now? That was the prime question that was raised before the Supreme Court. This question was raised by none other than Indian Medical Association itself. IMA took this particular petition to the Supreme Court. And if I may just take one more minute and explain, when Supreme Court was challenged with this question to answer, there was already division among the high courts. Some high courts were of the opinion that doctors don't provide service within the meaning of Consumer Protection Act because they provide something more than service. So you cannot really compare their activity with that of a plumber, a carpenter, painter, and things like that. But on the other hand, there were a few, high courts who were of the view that doctors also do provide service when they are charging for their service, and they are amenable to Consumer Protection Act. So this has led to an anomalous situation in India, where in some, states you could have challenged or dragged the doctors to litigation in consumer court, and in some other states you could not have. That is why this particular anomalous situation, which was prevalent at that point in time, IMA wanted to end. That is why they took the route of appealing to the Supreme Court. But at the end of the day, to cut the long story short, after hearing both the parties, Supreme Court came to the conclusion that doctors do fall under the ambit of Consumer Protection Act. Doctors do get covered under Consumer Protection Act, and the activity they do qualifies as service within the meaning of Consumer Protection Act. I hope you are, getting my point. That is what, the Supreme Court says. That is one among the prime reasons. I would please try to, note, this is not the only reason. This is one among the prime reason which changed the entire landscape of medico-legal, what you call as litigations in India. There is no database that is available which is maintained on a consistent basis. The best database I can rely upon is the database maintained by all your insurance players in the market. So if you really take the data from there and calculate, do the math, there is almost 1100% increase as far as litigation against the doctors is concerned. So we generally try to recognize this as one of the important milestone judgments in the annals of Indian, in the Indian law, which has triggered to a great extent the litigation against the doctors. But I would conclude by once again reminding Dr. Ujjvala, this should not be considered, or this should not be taken as the only triggering factor. There are multiple things. One is the increasing health cost. Second one is trust deficit that exists today between doctor and patients. Third one is doctors losing, much of their autonomy to their employers. These are other contributing factors as well. But because you have raised a, question regarding VP Shanta, I concentrated much on VP Shanta and sort of recap as to what happened there. Thank you.
Thank you. Very interesting. So I should also say I'm not a doctor, but I'm a lawyer, but I work in a hospital. But I'm lucky to be called doctor. But I have this privilege of straddling these two worlds. And I see a lot of, before we kind of get into more technicalities and talk about specific topics, I see a lot of anger and frustration on the side of doctors and say, why do we have to get into the legalities of this all? Why should we understand this? We're just doing our jobs and we should leave us alone to do our jobs. And what would you say to this?
Oh, that is again to me?
Yes.
Okay. See, as I said, generally I see the tendency of people blaming, because I also, like you, hobnob with the doctors little more than necessary. Let me put it that way. And, since last, 17 plus years, to be precise, 20 years, I do, specialize in this particular area. Everybody look at law as the culprit, is it not? They say, oh, this is lawyers, this is law. Law is being very barbaric against the doctors. I generally, have formulated, there are three very important, T's, three T's, which a doctor can possibly try to understand. The first T, according to me, is the trust. See, when I talk about the current, what you call a situation or scenario where doctor finds he is not being let to do his job freely, he is not being, let to do his duty properly, etc. There is a trust deficit between him and the customer. I don't know how I need to really emphasize this factor to all our audience, but I have come across some of the consent forms. Probably we are, we are due to discuss a little bit about, consent and things like that in this conversation itself. But I was, verifying some of the consent forms which were developed by some of the multinational, corporate hospitals, right? There, they straight up use a word, doctor and client. They don't even use the word doctor, customer, or doctor, patient. The word patient or customer is completely absent. They clearly say, you are my client. That, according to me, speaks tremendously about changing, what you call as times. So it is the trust deficit which actually makes doctors vulnerable. Whatever you do, rather than taking it as you are doing it for my betterment, you are doing to safeguard my life, you are doing it solely for my welfare, we start doubting that you are doing it for meeting your commercial ends. That is the first T, according to me. The second one is the tongue. It is about communication. The way, if you really look at the doctor's training, right from the word go, of course, I am not a doctor and I should not be really taken that I am, getting into some kind of a preaching mode. But this is what I have experienced myself interacting with doctors down the line for more than, 20 years when I interact. Somehow they require to be trained as to their communication skills. And there was a very interesting study that was conducted by a few of my doctor friends who are doing PG DMLE for their dissertation. And they studied, some doctors who are really working in some of the risk areas, high risk, what you call as treatments. But they have never faced any sort of a legal problem in their life. So they have some representative doctors and they studied. And they clearly come to the conclusion they could not really get into, sort of a legal issues or problems in their career is predominantly because of their communication skill rather than their excellence or their skill as far as medicine is concerned. That's why I say the tongue, communication plays a very important role. Don't think communication with regard to your patients, communication with rest of the world and all your stakeholders. That really makes how distinct you are as a professional. And the third and the last T, Ujjvala ji, I always talk about is the time. Look here, if it is, the time where everybody is about to celebrate birth of their infant and suddenly something going wrong, the way these people react is entirely different to a very old-aged man who is, whose death is to be announced. The way people take it and react is different. I hope you are getting my point.
Yes.
So when death takes place in, casualty, death taking place in ICU, death taking place in some other place, immediately, death taking place after treating the patient for about 1.5 months. So these all are timings, So your response, your planning, your strategy, all requires to, befit to that kind of demands of the time. So these three rolled into one, I would say, will determine why you feel yourself vulnerable today. Yes, of course, they feel law is a bad kind of a situation and things like that. I would probably, I don't know if you allow me to borrow 2 or 3 minutes of your precious time more. I just would like to say, the easiest thing you people can do is blame it on lawyers and law. But I always say, because recently I was asked to write and currently I'm completing that chapter for a IMA publication itself. There I try to raise two very important things. Recently, there is there was a unfortunate incident of doctor committing suicide, no? That
Yes.
lady got, she committed suicide. There, everybody is saying, oh, it is it is kind of it is a symbol how doctors are feeling constrained, frustrated, how they are harassed. But what has happened there? A police complaint is lodged, and police have registered a complaint, and there are divergent viewpoints. One press release says they registered complaint under section 300, that is, they started investigating the case for murder. 300 is about murder. Another set of reports say they registered it under 304A, that is rash and negligent act causing the death. But I would say, if you really look at this particular incident, keeping your what you call as emotions apart, these are the people who have went directly to the law. They have gone and registered the complaint, which is rather a better scenario than they manhandling the doctor or they trying to take law into their own hands, is it not? So we needed to really be very careful, with regard to this. We needed to understand, we needed to assess the situation. That is why not only legal, kind of an empowerment, I always say, other than law, you needed to develop certain soft skills because times have changed. Otherwise, you would continue to feel vulnerable. And blaming law and lawyers is not going to help you anyway at all, is what I would say, Dr. Ujjvala.
Absolutely. Thank you so much. I would now like to ask a question to Dr. Mani, who has such vast experience in critical care and probably equally good as an expert in medico-legal issues as much as maybe I can, if Professor Nandimath can permit me.
Much better than me is my claim.
Right.
No, because interaction with him, I have tremendously, they have given me greater insights.
Right. So, sir, I would, before we get into more technical questions, I would like to understand, how did you develop the interest in this topic, and how did you get to learn so much and know so much about medical legal law?
Ujjvala ji, it's a great privilege to be here and to listen to Nandimath ji. He's always been a pro-doctor man, I must say. It's very heartening. Now, see, as you might have noticed, if you have to survive and deliver properly, and also act according to, you have to act according to the law. And it's not just a technical understanding of the law. It is the spirit of the law, that you are answerable, okay? Whatever you do, even if you are supposed to be doing with good intention and for the good of somebody, it has to come within a framework. Okay. For us, the bigger than the law, or from where the law comes, is ethics. So no doctor can achieve excellence without being in line with ethics. And if you're in line with ethics, you may not have a technical knowledge of the law. You're usually compliant with the law. Okay. You see, there are 2 or 3 things in ethics. He talked about the 3 T's. Okay. What did he say? The first T was the trust deficit. Now, trust deficit comes because, we are not conscious of what is involved in the duties of care. Okay. That is law. It's also ethics. And duties of care is very simply put, it's beneficence, non-maleficence, and fairness. Okay, all this combined together is the best interest. So if you're acting in best interest, you are not just a contractual relationship. It's partly contract, but that's a small part. The big part is a fiduciary relationship. You see, this is what my understanding of relationship with the patient. No matter whether I'm in receipt of a fee, or there is a financial angle to it, but there's a financial angle in every interaction, okay? any and every interaction. You go to the law school, we have to pay the fee to the professor. Okay, the lawyers always have an interaction based also on fee. You may do it free of charge many times, but still there is some giving and taking. Okay, so it is impossible not to have a giving and taking, and that part also has to be recognized. So I'm not totally against this consumer protection coming under the Consumer Protection Act. However, it cannot be reduced to just a commercial relationship, because it isn't. It cannot be. Bigger and more important is the fiduciary relationship. And when the law is looking at the actions of a doctor, they have to take that into consideration. Has the doctor, he or she, acted in accordance with this understanding of fiduciary relationship, which has to be the best interest? So without that angle, you cannot have. Now, number two with the tongue. See, lawyers are endowed with a silver tongue traditionally. But you see, the lawyer's tongue is based on logic, okay, based on a flow of sort of how to relate things, okay, based on a principle. Now the doctor's tongue has to be rational, I agree. It has got to have the touch of compassion. Okay. So the trust deficit has come because we had become too much based on the cerebral side of doctrine. You know, and when you become cerebral, you are more self-defensive, because you're cerebral about your own protection as well. So we had become very self-defensive, and when this Consumer Protection Act came, and it was again looking at the profession not through this two components of it, only through one component. It had the application of the Consumer Protection Act became more cut and dried, and therefore it added to the trust deficit. And doctors, for their doctor, now the evolution of medicine has increasingly understood that we had become, as we advanced with the technical perfection, we lost out a lot in the foundation of medicine, which is touching the patient, okay, which is relating to the patient in a fiduciary relationship. Increasingly, we are becoming aware that we need training in communication, as Professor Nandimath very correctly pointed out. So, see, you can't assume that just because you've gone through postgraduate, undergraduate courses, you automatically become good at communication. That is a flawed understanding. Just like any other procedural perfection you acquire down the road in a surgery or a procedure or how you evaluate a case, you need specific training, structured training in communication. So we can put it all together, become better at expression, better at listening. Part of the expression is the listening. So we are now increasingly emphasizing the fact of active listening, because we are not giving enough time to listen. And that also takes away the trust. And it produces a barrier between the doctor and the patient. Increasingly, we are telling our juniors and ourselves, firstly, see how you're hogging the conversation. Okay. Are you giving 50% of the conversation or more? Patient. So this is happening. It's a process of evolution. You know, medicine is like looking at yourself and shaping yourself over a lifetime. And the third T, what did you say, sir?
Time.
Time. Yeah. So we have to give enough time. You see, when commercial side of your life is not overwhelming, and you give equal importance to the relationship, you will give time. All right. It is seen that in the outpatient, we are not giving more time than 2 minutes on average. But there are even if you give enough time to where it's required, you won't exceed 11 minutes. It's been all this been studied. So it is not that you have to spend an hour. But if you have got a proper structured training, you got an understanding of the basic principles of how you must relate, you will at least fall somewhere between 2 minutes and 11 minutes. And if you're properly trained, you'll utilize those minutes properly. So I would say I'm absolutely not afraid of the law. I think law is a friend. It is giving you, it is like having the traffic lights. It may stop you, but with a reason. Otherwise, you would get into an accident. But law has to evolve, just as medicine is evolving. With every new invention, every new procedure comes a new challenge of how do we put it in an ethical framework. It has to evolve. Now, we cannot do with Macaulayan 1860s law. We can't do with 1970s, 1980s law. Because a lot of evolution has taken place in the last 10 years or even 5 years. So we must keep on adjusting the law as well to provide the space, provide a more autonomy as well to practice as best as we can, and to understand what makes for this doctor-patient relationship. It's not just the doctor and the patient, it's the whole ecosystem. Okay, this is what I wanted to say.
Great. So now I'm going to jump right in and I'm going to ask you my first question, Dr. Mani, and then I'll move to Professor Nandimath, which is the most asked about topic, the hottest topic I would say for today, which is consent, right? So what is valid consent? Who can give consent? How is consent taken? How should it be taken from a patient? And I will then go into more specific questions, but let's start with that.
See, my understanding as a doctor, because we're taking consent every day. The basis of consent is respect for the patient as a person. Right. It is not just an act where you take a signature. It is actually respect in action. Okay. So consent is not just consent. It is informed consent. So unless you provide adequate information, and providing adequate information is also an art. You can't say you might die, as a side effect, okay? Although that's possible, but that is totally exaggerated. So a balanced information of why you're doing and what could be the anticipated or unanticipated risks is fundamental to respecting the patient as a person. When you take consent, you have to take directly from the patient. The patient is capable, has capacity. I think medicine, the ideals of medicine are in line with the agency of the person. Okay, you cannot relegate that to anybody else, except of course when you are a child or even with teenagers. They're relatively better, aware teenagers have to be taken as an individual. So this is my understanding. And then it is not just going through the motion of a signature. Many times what has happened these days is the signature is taken by the nurse, signature is taken by a junior doctor, or signatures taken after the procedure. Now, these are, I think, unforgivable if we have to follow the principles of respect to the patient. And this is very fundamental. And nothing can be done without consent. Nothing. There's no excuse of emergency or tiredness or your intent. There are, of course, provisions in emergency. There is no license in the name of doctoring to proceed with any act. That would be taken as violation, in my view, of the privacy of the body. Okay, that is also constitutional now, further supported now from our basic fundamental rights. It's again declared and emphasized. So that also includes refusal Consent is not going through the motion just before a procedure. Consent is actually respecting a refusal. You may think the patient may not survive by declining consent, but it is not a sort of giving a menu card and you tick it and do it. If you don't take it, don't do it. You also have the obligation of beneficence and non-maleficence, acting in best interest. So you are obliged to explain again. You're obliged to find other means of gentle persuasion. What you cannot do is be coercive. What you cannot do is act, overriding refusal.
So I will.
I hope you see, technically okay from your side. Yeah.
Yes, I think you started off very rightly so by not defining consent, but by actually talking about respecting the patient. And I think that's really the key to taking consent in its purest form. It's not the technicality of taking consent, it's the spirit of how we take consent and have they understood what they're giving consent for. So, I now take this question to Professor Nandimath to continue this conversation on consent. Doctors often find themselves in very tough situations with very little time, with many patients as well, not just one. They have several patients to treat, and they're very confused as in who should be signing this consent form? The parents are not there. Can the uncle sign it, or can someone else sign it? How have they? Sometimes they've explained, they've given consent, and later they've withdrawn this consent. Or you also mentioned something of accepting refusal of consent. But how does that actually play out in action, and what is the responsibility of the doctor in such a scenario? I put this to you, Professor Nandimath.
Thank you, Dr. Ujjvala. But before that, I just would like to take a cue from Dr. Mani, who very beautifully explained. And I try to really put whatever Dr. Mani said. It is not just technical, but that is the jurisprudential or fundamental premise on which the consent and medical treatment has been built. See, instead of that, what is happening today is the whole aspect of consent is been reduced to the technical affair of taking signatures on dotted lines, and that is where doctors are finding it very difficult to defend, these forms in the court of law. I would try to really put it in once again, it is just repeating or reiterating what Dr. Mani said, because according to me, this is one of the most contentious kind of, issues. The first one is, I say, you can divide the entire area of consent today in law into two parts. The one is, the medical treatment, which is not regulated specifically or specially by a dedicated statute. Like if you take medical termination of pregnancy, there is a dedicated law. If you talk of mental illness, there is a dedicated law. If you are talking of transplantation of organs and tissues, there is a dedicated law. So when you are involved in those special areas of treatment, I would say, please specifically try to scan through the requirement of the law when it comes to consent as well as other aspects of the, treatment. But wherever you are otherwise treating, you do not fall under that category, specific category where law regulates. You get covered under what we call as lawyers, Ujjvala, you understand it better, a common law, which is nothing but common sense. I don't want to make it too technical. Common law is nothing but common sense.
Yeah.
And that is why I would like to once again reiterate what Dr. Mani said. It is nothing but respecting the autonomy of the patient in either accepting the medical services or treatment or not accepting.
Yeah.
So that is why we try to capture the entire essence of consent law only in two sentences. I say, if it is a case of non-emergency, Because if it is a case of emergency, then you are put under duty to, treat the patient or take care, etc. If it is a case of non-emergency, consent is absolutely essential. Without consent, you would never be able to treat the patient. And I try to explain it to some of the junior doctors whenever I get the opportunity. It is like, let us say you have treated a patient like me, you have treated, and you have treated successfully. But your only problem there is, you have treated me successfully without my consent. You are certainly to be held liable. Please understand that, because you have infringed my autonomy. You have actually pierced through my autonomy. That is why you are going to be held liable. It is not on the account that you have treated me and treated me successfully. This is one thing which Dr. Rajmani made very clear, and I also sort of in my own words did try to put it in a framework. The second very important point, this is what is most disturbing kind of a trend. Then I will come to lack of time, the rush of the doctor and the demand for his time and things like that. Somehow there is some kind of a placebo that has been sold. And according to me, I hope my other colleagues, professional colleagues will, bail me out. Ujjvala, it is lawyers who have started packaging this placebo and selling to the doctors. See, consent is required for me to treat. Me means a doctor to treat the patient. It is absolutely essential. But it cannot act as a defense from negligence. That is why trying to have about 3 to 4 pages, 10 pages. Let me put it this way. I have clearly recorded there is 33% or 1/3 chance of death. It's a high risk sort of a procedure. I have explained what is meant by high risk procedure. Sir, out of 3 patients who have underwent this procedure, 1 has not returned at all. Does this mean if the death takes place, I am completely protected? The answer is no. So this is where doctors are getting enamored by this placebo, saying that, okay, if I write a bigger, consent form, I would feel protected better. There is nothing of that. It is required for you to touch the patient. Once you show that I have touched the patient, I treated the patient with his valid consent, the role of consent gets over from there. Then we get into the next focus. Next focus of the law is, okay, let us now consider whether all the standard care is provided by the doctor or not. If that is not provided, we will still hold him liable. It has nothing to do with your consent. So now you look back, how much of money, how much of infrastructure, how much of your efforts you are investing in that placebo, which some of my own colleagues have for their commercial interest sold you. Now, having said this, many doctors do ask me very pointed questions. Sir, consent appears to be too tedious. I don't have time at all. I have 10 patients, 20 patients. I work in a critical care unit, or I work in a emergency. So I have lot of patients to be taken care of. How can I spend so much of a time? That is because you have unnecessarily created consent document so lengthy. But if you really look at, this is what we did with IMA, Trichy. Because IMA challenged me so much and we collaborated together and we have created a format. And that format, we insist the doctor should administer, that is the treating doctor should administer and nobody else other than him. And we also clocked many doctors, and the average time the doctor has taken in getting the consent form is 3 to 5 minutes. The maximum time he has taken is 5 minutes. The lesser, some doctors are quick enough, they have taken 3 minutes. If you think today a doctor contends that he doesn't have 5 minutes of the time while treating the patient, then I rather doubt his competency, capacity, and the kind of intent. So this is rather a myth that I don't have time at all. Because you can't do your entire clinical examination starts with respecting the autonomy of the patient, and without consent, you cannot go. I hope the first part of your question, Ujjvala ji, I have answered. Now comes the next. When you have if there are three qualifications, the first qualification is the patient has attained the age of majority. That is, he is above 18. Then he alone can consent to any treatment. And number two, he has orientation. That is, he understands and he is quite capable of taking, decisions all by himself. So there may be momentary loss of orientation, or there may be permanent loss of orientation. Permanent loss of orientation, we call them as people of unsound mind or those who are mentally challenged, etc. So if these three conditions are satisfied, that is, if the person is capable of consenting, then he alone can consent, nobody else can consent. That is point number one, right? The point number two, if one of these qualifications are missing, let's say he is quite, bodily competent, full age, but he has lost his orientation, he is in shock, utter shock, or he is unconscious. In those such circumstances or situation, a proxy consent would suffice. So, but who should be the proxy? In America, to overcome this, they have digitized or they have formalized this. They clearly say the hierarchy. If X is not capable of giving consent, then who should be the immediate, person who should be giving the consent? There is a hierarchy created by the law in some of the states in America. But in India, we don't have it. It is still subject matter of common law. So that is why I would rather say, instead of feeling constrained by this kind of absence of law, you can use it to your advantage. You can take any person whom you feel to be in charge of, the scenario. He can be even a neighbor, attendant, on whose consent you can go ahead. But what you need to satisfy yourself is whether the other person from whom you are seeking consent is the best and the proximate person among the available group of people. It is like, wife is also available, neighbor is also available. I would rather go to wife than the neighbor. So that is one, deduction. See, among the available group of people, whether he is the most proximately related person to that. That is the first thing. And number two, whether that person has, right, whether he demonstrates, resonates, his sole interest is the interest of the person who is incapable of giving consent. That is where most of the doctors frenetically call me. I do get this kind of calls once in a while. Sir, I have a person, especially, in Mohammedan community, they call. Like last week, I received a call from Mumbai. They said, sir, there is a critical patient who needs to be operated. He has two, what you call as wife. One wife is saying, you go ahead and do whatever it takes, doctor. The other wife doesn't want him to be, treated at all. Now, how do I determine both are legally married, legally recognized wives of that person? Then I said, apply this particular theory. Who has got the central, sort of an interest? You go ahead and do it. And otherwise also I said, in case of emergency, even doctor doesn't require proxy consent also. That is another very important perspective which needs to be superimposed to understand how vibrant and how progressive the law is. And if you understand these nuances, right, Ujjvala ji, as Dr. Mani said, you are basically using it as what you call as an integrated sort of a treatment protocol of respecting the, patient's autonomy, respecting his intent rather than you force treating him. Then I don't really think you would have any problems on procedures, right? Maybe I would stop here and revert back to you.
Yes, I think Dr. Shashi wants to ask a related question.
Yeah.
Dr. Shashi?
He is on mute, I suppose.
Thank you, Ujjvala. Thank you, Professor Nandimath and Mani. Look, I have one question about consent itself. See, it is not, we work in a very vulnerable place like in ICUs or children or where direct consent in the morning. You did mention about having a hierarchy, which is not possible in our country, and then we end up doing a non-hierarchical, whoever comes, take a common sense and then go ahead. The biggest problem comes in when we start giving an explanation of the procedure or the prognosis or anything, even if it's going to be in the simplest of the languages at the end of the day. And the understanding, we don't have a particular level of, I don't know whether I can call intelligence, or I don't know what it's called, but everyone don't really understand the nuances of what happens to a person, and very frequently we do get back telling, none, I mean, in our own languages, we didn't understand anything what you explained yesterday, and you would have done a lot of things. And I mean, we won't be, if we are going by what Dr. Mani mentioned in terms of, or all of you mentioned in terms of having an ethical principles and walking that path all the time, we should not be worried about it. But how do we actually get away from this in terms of their understanding? Do we actually have to go deep into that, or general, or ask them to write down what they've understood and give us as a consent form? So many things can potentially happen, and it's all time consuming. Yes, Dr. Mani.
You see, this question, we may not have a hierarchy of people capable of representing the patient, but we do have the concept of next of kin or next friend. You know, that's very evident in the TOA. Okay, for renal transplant, we are doing all the time. Are we not taking consent? There's no hierarchy, but you're supposed to take consent from the next of kin. So there is a hierarchy given there. Spouse is number one, then so on and so forth. Now grandparents and grandchildren have also got added in the last rule book updated in 2014. Now the issue is, you can always find next of kin. In an exceptional situation, you may run into a problem of what Professor Nandimath mentioned, more than one wife and all that. Even there may be a seniority among the wives. No, I reckon. So there may be somebody who may be taking charge, for instance, okay? Or somebody who brought the patient, or you can ask the family, which person would you identify to represent your family? We do that often. Now, another question, Dr. Shashi said very correctly, this is what we run into every day. You explained everything, they come back and they are totally blank. Okay, they haven't understood a single thing. Okay, so the technique of communication, as we teach in workshops and has become standardized now, is ask, tell, ask. Firstly, you ask, what have you understood? Okay, what have you understood about the prognosis? What have you understood about the current position? So however naive and partial and immature the understanding may be, you may build up from there. You at least understand. And this is not true only of medically illiterate or overall illiterate people. It's equal with pretty sophisticated people who have received sophisticated education. When it comes to medical understanding, they are pretty babes in the woods, by and large. So ask, tell, ask is a very important communication technique which we should apply in practice. Professor Nandimath said another thing. You see, you must take consent except in emergencies. But what our understanding in practice is, even in emergencies, you have to take consent wherever possible. Because in emergency, you can't take from the patient. You have to again use the next of kin principles. Next of kin or next friend that is available. You can't have all the kins in one place. I don't think the law is so non-pragmatic at that. Only who is approachable, who is there available, who he or she available, only you can take the consent from. If you cannot, you do not have time even for that, or you do not have anybody to give consent, then the doctors can give consent. But that's not unilateral, one person. It has to be at least two doctors. At least two doctors. Sometimes you get anonymous patients. You have no kin. It doesn't mean that we have a license to just violate the body. Even then there is a procedure. There has to be a documentation of two people agreeing with what we need to do. Okay. It's, of course, they're sometimes very dire. Somebody comes in a cardiac arrest, you jump on the patient. Those are there, exist in that case also. Afterwards, you have to justify why you had no consent, that you had to go that fast, without even attempting to take a consent in things. So I think the law is very clear. Our ethics are very clear, and it's in the world, the consensus standards are also very clear how we have to improve it. There is no ambiguity.
So I'm going to move to within the gambit of consent, there's a slightly even more contentious topic, which is on the whole idea of DNR consent, right? The do not resuscitate consent, which has become very, very common in many hospitals across the country. And I think we need to shed a lot of light on this, right? Because this is most important, especially for everyone in the audience today. Is it even valid? Can we even take such a consent? What happens when you take this consent? How does it work? So I'll put this first to you, Dr. Mani, and then go to Professor Nandimath.
Of course, DNR is valid. Do not attempt resuscitation.
Sorry to interrupt.
Yeah, it is valid in India. It is valid in India, and it has been validated by no lesser body than ICMR. And it was published as a guideline, consensus guideline, in 2020, I think, or 2020. So I was part of the task force, and of course, it was done with several rounds of consultations, and there were, I think, not only people of medical profession, but also legal profession, and there were also administrators, medical administrators. And also there was consultation with the lay public at one point. So whatever it is. Now, you see, we have been reinventing the wheel in our country. We haven't kept in touch with the developments on the practices, on the ground for a long time, because the first DNAR order was written in 1974, a documented DNAR, written 1974, USA. And there was a codified law in the US in 1988. The whole of the developed world, developed in medically speaking, has a provision for DNAR. Now, what is DNAR? It is do not resuscitate, means do not do CPR. DNAR doesn't mean is euthanasia, or DNAR doesn't mean you withhold any life-saving or any life-supporting system. It's got a single point definition. This also we must understand. We conflate the whole thing. Okay, the whole gamut, you can't have 300, 304, 309 all as one. Can you, in law? You can't have. They all are different. They have their specific definitions, specific application, and specific redressal. Okay. So similarly, the simplest end of the spectrum of treatment limiting decisions is DNAR. Why? Because CPR is not a default procedure. CPR is not a mandatory procedure. It's like any other medical procedure. It has to be, the patient has to merit that procedure. Okay? The medical indication has to be there. It cannot be out of context that anybody having a heart stopped has to have a CPR, because it can do a lot of harm when not indicated. There are people who don't have much chance of any survival, but if they may be just kept alive with a CPR, they may end up with a vegetative state, which is a fate worse than death. This is not the outcome desired by the medical world or by any patient or by any reasonable person. So it is already mandated by common law, I think, by common sense, as you said. Okay, you don't, but common sense is what? You do a medical procedure to benefit somebody. You don't do it as a ritual. Okay, that is wrong practice of medicine. It is actually unethical. It is actually against the mission of medicine, and it is actually not in to benefit the patient or the society at large. So that is why, if, for example, in COVID, and first flush of COVID came, it was extremely infectious, and we did not know it was more threatening than it is now. Now, a CPR, a futile CPR, could have exposed a huge number of professionals doing the procedure. It could expose other patients. It could expose the whole hospital to transmission of COVID. It's not justified. It has been estimated that in the ICU, when already some form of resuscitation is going on, having a CPR is successful only in less than 5% of patients. If you take success as a meaningful recovery of neurological function. That is why DNAR has come about. There are DNAR guidelines and consensus and rules all over the world in any standard, any medical ecosystem which is standard. So I do not know. I think we have been confusing DNAR with other issues. We have not really understood it in context. So if we are not aware of a certain IPC, we cannot discuss it. You have to first know the definition. So now, since this DNAR, and that is why it doesn't violate any law. There's no mention of any DNAR, any law or any case law that I know of. Just because it's not mentioned doesn't mean it is not in practice. We are supposed to follow evidence-based medicine. Okay? That as a principle is accepted in the legal world. In fact, they insist on it. How do they judge negligence or otherwise? By evidence-based medicine. So if you're following EBM and you're not following when not to do a procedure, that is not being aligned with EBM. So whatever is medically indicated, medically standard, should be acceptable to law, even if it is not aware of it as of now. So I practice DNAR regularly. And if for some reason I have a case file against me, I would welcome it because I have a chance to present the case and defend, and that may benefit a lot of people. Dignity in death is extremely important. It's not just about dying and rescuing people. How they die is extremely important. The death may be so bad for the individual and death may be so bad for the family that may destroy it. One useless CPR may cost the family 50,000 rupees within a span of half an hour. So let us understand what we are doing. And it may expose, maybe in a pandemic, it may expose other people to fatal illnesses. So we should be responsible. All medical treatment is based on sense of responsibility and also on data. We are doing something. Why are you doing? Are you just doing it ritualistically because it's supposed to be done, or it is actually necessary?
Fair enough. I think Dr. Ghanshyam has a question. Would you like to ask a question? You're on mute, Dr. Ghanshyam.
Good afternoon. Dr. Mani, with respect to the same thing, sir. Now, the ICMR, as you said, DNAR is only not for attempting resuscitation. Now, if the family says that they don't want their patient to be put on either a ventilator or RRT or any other form of invasive support that is needed in the intensive care unit, will this be legally valid when we document it and take a consent? That is one question. And the second question is, sir, should we revisit the DNR on a day-to-day basis to see if they are revoking it, or if they give it once, is it applicable, as long as the patient stays?
Wonderful questions. Well, the thing I had missed out in my previous description of DNAR, like any procedure, being respectful of the patient is to inform. It is not to take a unilateral decision, except in certain exceptional conditions. Okay, well, they will come to that. By and large, CPR can be, the need for CPR can be anticipated. A certain age or a certain set of conditions in the patient or a certain context of the illness, you should be able to anticipate that this patient may have a cardiac arrest. So that is the time to discuss if it is feasible, including the patient, if not, talking to the family and getting to know the values of the patient. You see, there are a lot of gray areas in medicine, okay? The black and white situation is the exception, okay? The bulk is in the gray area. You will not be absolutely sure whether the patient has a realistic chance with CPR or does not have. If there's no realistic chance and it's crystal clear, you are not obliged to offer it, okay? If there is a realistic chance, you go ahead, have a CPR code, but you must ask the patient also, right? Some patient don't want, it's okay. It's like any other consent. In the gray area, you need to talk, okay? You need to say, the heart may stop and possibly there are not great chances of doing well, okay? And if it doesn't go our way, it's not just that the patient may not survive. Sometimes they survive with huge deficits. Is that acceptable to you? So this sort of a conversation has to be done. Similar conversations are with life support systems. You said withdrawal withholding? Of course, withdrawal withholding is constitutionally valid. Why? Because we had the 2018 judgment, common court judgment, where they held it to be valid and with certain, of course, preconditions. And since it is valid, you have a right to exercise your autonomy even when you lose your capacity in the future. So when you are not lost your capacity, you can execute an advance will. Now you can create a legally valid advance will document and also appoint a proxy. Okay, this is there in the world for a long time. Okay, again, for 40, 50 years, there has been advance will, there has been all these things are going on in the world. We have kept ourselves like an ostrich, and not wanted to see these are going on in the world. We've assumed this is not for our country because we don't want to come to grips with ethical dilemmas, right? Now, if you come into an ethical question, we want to run away because it seems a bit too a mountain to climb. But you cannot practice good medicine without the ethical questions being confronted and resolved. So the withdrawal withholding has to be, there are principles. Now, court has laid down very complicated 3-tier procedure. That's not possible, workable in the intensive care situation. So we look at the principles. The principles are don't have a unilateral decision. Principles are have a collegiate decision. Principles are open up the question with the family. Okay, patient directly if capacity is there, open up and take a joint decision, so-called shared decision. These are the principles. And now Indian Society of Critical Care Medicine, Indian Association of Palliative Care has guidelines, published guidelines of 2014. It's a 20-page document, gives all the background, and it gives a certain algorithmic approach to how to get an end-of-life decision. So if you combine the Supreme Court judgment and the medical position, not only within our country, but international medical position, you should be able to deliver these sort of decisions.
Okay, so I think Dr. Basjinder has a question. If you could quickly ask that, then I'd want to move on because in the interest of time, we have about 45 minutes left. So,
thank you, Ujjvala. Good evening, Dr. Kumar. I just wanted to ask a very layman question. Supposedly, a patient comes to my ICU. Relatives from the beginning, they have prepared their mind that we do not want DNR. We want, DNR. They give it in written. हमारे पेशेंट का अपने CPR नहीं करना है, बाकी सब कुछ करिए, जो भी हो सकता है. Patient gets started on inotropes. Now, what will be my aim? Should I go ahead with the lines? Should I keep on escalating the vasopressors? Because it happens in day-to-day life. Ultimate, the thing will be DNR. They have given it in written. But should we continue vaguely like this, knowing in our mind that ultimately the efforts will be futile? Thank you.
You see, When we say DNR, we must mean it in the narrow, precise sense. Okay? You should not mean it in the broad sense of withdrawal, withholding. Okay? If you mean it withdrawal, then talk about withdrawal. If the family says DNR, I don't want CPR, you tell them, oh, do you mean only CPR or any kind of intervention? Right? If they don't give you consent for any kind of intervention, including vasopressors, you should not do it. And take that refusal of consent documented. Because without documentation, nobody is going to believe you. And without the discipline of documentation, we also tend to be loose in our practices. So it is for us as well. It is not a constraint. It is the way to be doing things. So we must understand that in law and in medicine, we must understand what we are talking about. DNAR only means don't do CPR. You may do everything else short of CPR. That's okay. If that is the consent, then do the other things. If they say you can do vasopressor, okay, you can give fluids, you can give medicines, but don't put a patient on ventilator. Yes, then that is a separate consent. Refusal of ventilation. There are DNI also, do not intubate orders. That's also becoming very popular in India and very common in the world. So you may do everything. You may even write an expensive prescription. However, if you do not intubate is documented, then you should not intubate. That's a violation if you do so.
True.
If you think it is indicated, okay, if you think it is indicated, family is refusing, then talk to them. Put forward your case. Tell them why you believe the patient may benefit from intubation. But if you also believe in the heart of heart that what the family is requesting is reasonable, go along with them, support them, and don't do that act.
Great. I am now going to move to the next topic. So in the interest of trying to cover more questions, a huge portion of the audience today are people who are working in a tele-ICU setup. So naturally, we have a lot of questions around tele-ICU and how the legalities within a tele-ICU. So I am going to get started with my first question. I will actually start with Professor Nandimath and then come to Dr. Mani, because I know there's a lot of things that you can add as well. But I'll start with strictly with the law and then come to you, Dr. Mani. So Professor Nandimath, when we talk about tele-ICU, there's clearly a hierarchy of orders that are followed, that a doctor gives an order to the doctor on ground in the hospital, and then there are nurses, and there's an entire structure there. So I will put it to you first very clearly, whose responsibility is it if something goes wrong with the patient? Who is considered negligent? Where does the blame fall?
Okay. See, if I've understood your question, Ujjvala, if let us say there is something called as, if you go back, the best way you can understand the answer is by taking recourse to the, earlier way. We used to talk about doctor-patient. Don't bring telemedicine immediately. You have a doctor on one hand, you have a patient on the other hand. So there is a relationship that gets existed between them, and doctor would be held liable for all the consequences of his treatment, is it not? But today, as the time progressed, right, as science advanced, it is not one doctor who is treating the patient now. It is group of doctors trying to treat one patient. It is multiple doctors grouping together as a team trying to treat a patient, is it not? So which doctor we are going to be holding liable? That becomes a very important question. But in 99% of the cases, I always say, there is one person who is ultimately ready to answer the blame, namely the hospital administration who has put this team together. Because Supreme Court also, in Maharaja Agrasen case, they have made it very clear. When it came to whether the doctors, are to be held liable or the hospital administration is to be held liable, they answer that question. If the patient has gone to the hospital and not to the doctor, the hospital has to take responsibility at the end of the day on its shoulders. Irrespective of the fact whether the doctor is on the rolls of the hospital, whether he is, on call doctor, he is only a consultant, or he is even an ad hoc consultant. Ad hoc consultant means he is not, you don't even have a consultancy contract with him. Because the situation warranted you to avail his service, I simply called Dr. Mani. It is one-to-one call. And Dr. Mani was also available luckily at that point in time. He comes and joins that team of doctors. So in 99% of the cases, it's the hospital administration which takes the blame. Or is liable, is it not, if something goes wrong? But remaining 1% of the cases, if at all you try to, put it very creatively to lawyers and challenge the law, saying that this is a team of doctors who are treating the patient, who among them, need to be taking the responsibility. There is a captain of ship theory. We again go back to the analogy of law. There is something called as captain of the ship theory. So you cannot have a team without the captain. So ultimately, the captain being a leader should be owning the responsibility. Right? This framework you apply to a telemedicine situation, that's all. Because many people say your telemedicine guidelines today don't speak about this. This is a gray material as far as, telemedicine, etc. No. Look, why that doctor on the ground, if you talk about the doctor on the ground consulting some other doctor, is either because that doctor is not competent per se, and he requires additional guidance. And that is for additional guidance and direction, he consults the senior doctor or the doctor, and the only medium taken is your technology. So the person who is actually guiding that doctor on the ground, both of them are equally reliable, and more is the person who is guiding him. That is why, if you are involved in a telemedicine kind of a scenario, so Cloudphysician, today, both are providing that kind of a solution. What they needed to really make sure, according to the law, number one, they have to really have some kind of a common platform where the communication is with Six Sigma efficiency. There is no, one person saying something, another person understanding it differently, and one person giving direction to the, doctor on the ground, and the doctor on the ground is unable to follow that direction without loss of time. So they needed to really empower themselves so that they are capable of exchanging vocabulary very efficiently. That's the first requirement. The second requirement, because you are ultimately in charge of the situation, and the other person is only acting as your agent, you are to be liable. You need to make sure whatever directions you give, that person follows that direction precisely. So that kind of a control also you need to have. Administrative control is what I say. I don't want to make it little more, much more technical and try to bring in some kind of borderline, sort of imaginary cases here, because that makes our debate or discussion totally theoretical. This is where I think, Dr. Ujjvala, I would stop and see whether there are any precise sort of instances where you want me to apply this framework to.
Oh, Dr. Rajesh has a question, I think. Let's hear from him.
Yeah, hi, sir. So I just have a question with respect to involving the other specialities. Let's say the hospital or where I'm working don't have in-house specialties, and we requested a friend or somebody I know who's a specialist in that. I called him up and asked him to have a look of my patient. So by some chance, or like he may not make it in time, and the patient deteriorated or some bad thing happened to the patient, then who will be the liable? Because the doctor on ground, or he's the captain of a ship, and he's taking all the responsibilities, but he already called in the help for some other doctor because it's out of his specialty, but there is some reason the doctor may not make it on time and the patient deteriorated. Then on whom does the legality stands in this case, sir? Thank you.
You want me to answer or Dr. Mani? Because when you, Doctor, raised your hand, Dr. Mani was talking. So I just want you to clarify that.
So, anyone, sir, both are experts.
So you are trying to be very discreet, Dr. Rajesh. That is actually the point today. Look here, you are trying to look, law appear all pervasive in the sense, look here, Dr. Rajesh, let us say, you are the doctor who is treating, right? There, I try to really, make it appear very simple. When you accept the patient, that is doctor-patient relationship, when it gets established, it is the patient who comes with the offer to the doctor and he seeks medical help. You get my point, doctor. At that time, whether you accept the patient or you don't accept the patient, there, one of the important parameters is don't accept the patient beyond your competency. That is, if you are not competent, because you can easily make out this is something to do with heart, it is something to do with kidney, or it is something to do with X or Y. At that time, don't end up accepting the patient beyond your competency. But don't stretch this particular analogy of law beyond a particular level. Like, you accept the patient who is, who comes with you with some kind of a high fever. Since last 3 days, he says, sir, I am having a high fever. At that time, you accept the patient and then later on realize it is, he requires to be directed to another super specialist because you clearly diagnose it cannot be handled by you. These are two different things, right? But when he is under your treatment, his situation suddenly becomes so aggravated. It requires some other person who needs to really treat, a specialist treating him, taking over from him. Sorry, taking over from you, right, doctor? At that time, you fetch for a super specialist who are very, there is a scarcity of these super specialists, is it not? So when you're fetching him, there is a delay. I don't really think law will be very harsh and hold you liable because there is a delay. It is not every, kind of a death, or it is not every error of judgment on your part, the law will hold you liable. Don't think that way. That is what I am trying to say. If these type of situations reach to the court of law, as a judge or as your lawyer, I will ask the judge to look into. Sir, you place in the place of Rajesh any other reasonable doctor. He would have also done the same thing what Dr. Rajesh has done. You can't expect Dr. Rajesh to possess all the skills in this world to treat the patient, is it not? I hope you are getting my point, doctor. So if you apply that, I don't think what you have done is reasonable. What is reasonable? Fetching for a specialist is reasonable. But what is most unfortunate and beyond everybody's control? We have to blame only the fate of that deceased patient rather than anybody else. Yes, that specialist could not arrive on time. That's all. You cannot be blamed for that.
Yeah. Thank you, sir. Thanks.
Sharath has a question, I think.
Yeah. Since Dr. Mani clarified the definition of DNAR, I would just like to go ahead and ask him about the legality of the words llama and dama. So are they valid? So are we right in using them on paper?
Dr. Mani.
Sir, you are on mute.
You see, lama and dama are purely a self-defensive and ill thought out practice that doctors have adopted. Okay? Just calling something a lama doesn't absolve us of the responsibility to look after the patient's interest. Okay? More often than not, what happens is the patient is very sick and struggling, and family has run out of money. And they say, what can be done? Then they say, okay, you take the patient home, sign this document. So this is not ethically justifiable, all right? Nor is it sanctioned by any medical practice, okay, known to us. I think it's a very heartless practice, in short. It's a heartless practice. I strongly discourage lama in my own practice, and I very nearly know lama, for the last 15 years, because wherever I've gone as a leader of a team, I have discouraged very strongly. And in fact, lama doesn't protect you either. And that's very clear from that Adya There was a young girl who died of dengue in Gurgaon, fMRI. And when the child died, she was, when the child was very sick after 15 days of ventilation and all that, the family said, why can't you stop these things? Why can't you say there's no prognosis, then why don't you stop the ventilator? They said, no, we can't do it. It's against the law. We'll send you Lama. We won't take the ventilator off. And somewhere in the ambulance, somewhere in the middle, you take off everything. I know the details because I was sent all these data also, because there was I think a committee set on this. Now it's a 10 crore suit. See, you cannot justify subjecting a child to such cruelties as yanking off the tube in an ambulance without any measures, palliative measures to relieve distress. Where is the justification? Does signing a document, Lama, justify the fact that you have just sent without warning the family, okay, what can happen elsewhere when this is taken off, and without giving them any relief as to how it can be done? What I would have done is I would have taken an end-of-life decision, taken a decision to withdraw, and I'm absolutely confident I would not have gotten into this trouble. I would not have a case against me, because I would have a good relationship with the family. The family was so angry that they got out of suit. They came on TV in so many programs and just vented out their suffering and pain. So I would have taken, because I have said there is no prognosis. So then why can't I take off? When the family is requesting, I would have done that, and I would have given anticipatory sedation and analgesia. Counsel the family properly, because the psychological pain is also real, and in fact has far-reaching consequences. You can have post-traumatic stress disorder for lasting an entire life, okay, and the memory will never fade away. So I would counsel them, talk to them. If need be, I would have taken the help of a psychologist, clinical psychologist, okay. If need be, taken the help of any religious personage they would have liked, okay. Have the opportunity to get all this help and done in a proper way. And I would not have sent a patient Lama. So we are sending patient Lama even today, because there was a study called INDICAP study, a point prevalence study of all the ICUs in India, across India, 135 ICUs. The Lama practice is prevalent in 7.5% of all admissions. Not a joke. It has only increased from a point prevalence study done 10 years earlier. So what has happened is we are not learning from bitter experience, because we are not looking at it from the overall perspective. We are looking at it from a selfish perspective of protecting ourselves. Even that we are not accomplishing properly, because we are not using our brain or heart. So Lama is not sanctioned by anybody. I wrote a paper in 2009 on end-of-life decisions in an Indian ICU. It was published in the Intensive Care Medicine. One of the questions that the reviewers asked was, what is this Lama? We've never heard of it. Can you tell us more? And it so happened, when I searched the literature, this sort of practice doesn't exist anywhere else. The usual Lama that is done elsewhere in the world is somebody comes to see a doctor, he advises him admission, he says, no, I don't want, I'm going. It is not in the context of a ventilator stuck to your airway, and the family is taking the patient away in anguish, okay, and in conflict with the treating team. Such a thing is not heard of. This is not ethical, okay. So this has been my campaign, not to do Lama, to care for the patient holistically. We are obliged to care not only for the dying patient, but also obliged to care for the family which is suffering. And we should do all we can to prevent suffering.
Thank you, sir. Thank you.
I can see a question in the chat box from Dr. Anisha. Going back to the tele-ICU topic, her question is, what happens when the tele-ICU team recommends a course of treatment, but the bedside team does not take the advice and there's an adverse outcome? Who takes the responsibility?
You see, as far as telemedicine is concerned, I'm totally in sync with Professor Nandimath, okay? You see, there is some captain of the ship. Okay. There is a treating team with a captain. There is a doctor under whom the patient is admitted. So ultimate responsibility of whatever transpires with the patient is that patient, that person and the team's responsibility on the ground. It cannot be somebody who is giving advice from a distance. They have chosen to take that advice. Okay, whether they choose to take that advice or not to take that advice is their prerogative. Okay, if you take a second opinion, it's not an obligation to follow that second opinion. Okay, you take opinion. I mean, that's correct. You may integrate parts of it, okay, in your ongoing treatment, but there's no obligation to verbatim take everything. So that itself doesn't amount to negligence. An adverse outcome, Professor Nandimath has clarified that an adverse outcome doesn't in itself, become negligence. If it were, then we were all totally negligent. See how you handle that. What were the run-up to that adverse, and how did you handle that adverse reaction? And whether you've done it according to standards, that is where the test of negligence lies.
Is there anything you'd like to add, Professor Nandimath? You're on mute, sorry.
No, I am so glad that Dr. Mani very boldly stated what I sort of tended to conceive. Because if I say like you, Dr. Mani, people will think, I'm not a doctor and things like that. See, believe me, you, Dr. Mani, maybe I would keep it as a conversation between me and Dr. Mani, or to some extent, Dr. Rajesh and Dilip Raman. See, I'm today advising nearly 7, startups who are trying to create some kind of an engine for effective telemedicine. And they have already received funding. And now I do not know, in the midway, they have come to me asking for a legal opinion. See, if I am providing, let us say, telemedicine consultancy services, or take, for example, Dr. Mani is providing that kind of a service, he has to be completely the commander of the ship. And your entire documentation should ensure that. That means you are not going to leave, as far as a certain part of your activity, no autonomy to the people on the ground. They become your agents. Because what is law of agency? Ujjvala, you will understand. You have a principal, you have a agent. Agent represents you and he binds you. If he does not follow your instructions properly and bungles up, or he goofs up the thing, but still you are to be, taking the responsibility as far as the third party is concerned. But later on, you can recover from that agent for not following your instructions, indemnify him, you, etc. That is a secondary remedy. See, but today, most of the people don't really understand the criticality or legal criticality of this. When documentations and things like that happen, they say, okay, you are also doctor, I am also doctor. It is not to be mistaken as a second opinion. He's not consulting you for a second opinion. He is going to really put you in charge of the situation. That is point number 1. And point number 2, I don't know how Ujjvala ji herself will take me, because she is a lawyer, practicing lawyer. Many people ask us, sir, what we should do because your guidelines are silent. Sir, how do we really, how do you help? Rather than you allowing lawyers developing the protocol for further development of, telemedicine, doctors should fill that vacuum with kind of scientific kind of engagement.
Yes.
Otherwise, what happens? Quixotically, I prescribe something as a law or something as a dictate, and that completely kills the whole development of, telemedicine in the country. That is why, more than us, you can consult us. I'm not saying don't consult us. Involve us also as part of the team. But you need to be, in control of the things. Yeah. You need to develop scientific protocols which would, augment this particular scientific development, which is going to provide tremendous amount of solace to millions and millions of souls. And it is going to bring affordability and access to, medical remedies in the days to come. That is what I thought. I would just add to what Dr. Mani has already said.
Yeah, absolutely, sir. And even when a judge, before they give a judgment, they are looking for guidelines, they're looking for documentation that is out there, that's validated by groups of doctors. They're not looking to take judgments without taking these into account. And I think this is such an important point. I think doctors have to get into the technicalities of medical legal law and actually put documentation down, which is not meant for the medical community, but meant for the people at large. And I think that's a very, very important point. And hopefully this series and these conversations are the beginning of that. And I can see a lot of doctors also getting involved. So I see Dr. Basjinder has a question. Could you please go ahead and ask questions?
Dr. Mani sir, I have two situations where I have personally been entangled. I'll share my experience shortly. First is that in the part of the India where I work in Punjab, the files are not under intensivist. The patient won't get admitted under intensivist. And I am as a senior doctor, I do most of the night duties, where I am sitting at the bedside of the patient. I am auscultating, I am finding everything. And as per protocol, my junior will talk to the primary person under whose the patient is admitted, and supposedly something sudden deterioration happens. I have planned a certain sort of treatment, but the primary consultant, who is not master of that field, supposedly hemodynamic monitoring or anything else, he says something exactly opposite to me. What should I do? In many situations, I have followed myself, and with a good outcome, because then I have to tell them that I am the person who is by the side of the patient, and I can judge better than you who are sitting at home, because I'm mostly on the night shifts. And patients have shown good outcome also. And in the second situation, somehow we have to follow the primary consultant's advice, and then adverse outcome has come. And then how should I defend myself? Because I was the person who was in charge of the ICU at that time. How should I handle such situations?
I think Dr. Basjinder has asked a very pertinent and extremely important question. And in the early part of my career, these were the very challenges we faced, okay? Because those who are not primarily trained in intensive care, they remain in charge of the patient, on paper. So this dichotomy is real, so that is why the controversy of open versus closed ICUs have come about. In the open ICU system, doctors who may not be particularly trained in intensive care, but they admit patients, okay? They visit twice a day and write some advice, but don't monitor 24 hours and are not in the rescue role, okay? And but they seem to control what is to be written or done on the patient. And those that are trained to do this sort of job, the rescue job or the critical illness job, they don't seem to be vested with the authority of primary care of the patient. So this dichotomy, our country as a whole, our ecosystem is not properly sorted out. Over years, we have fought our way, clawed our way to a situation of, in many places there are truly closed ICUs where the intensivist is in charge. But in 85% of ICUs now, according to the INDICAP study I mentioned, they are so-called semi-closed ICUs. Semi-closed means that for certain roles, the intensivist is in charge, and for certain others, it's the primary physician. Still, this sort of a dichotomy is not fully resolved. In some countries like Australia, when the patient enters the ICU, the primary physician, it gets out of bounds for it, because the patient is completely given in the charge of the intensive care team. And they're also trained in such a way. They have an integrated course of 4 years, and where they train people also in multiple disciplines. Be that as it may, these questions from the legal perspective, Basjit Kaur said that if I take a decision and the outcome is good, okay, nobody says anything, okay? If I take a decision overriding the primary physicians, and the outcome is not good, then whose responsibility it is? Or I follow the primary physician, outcome isn't good, but I'm carrying the baby. Now, from the legal perspective, one who is on paper the captain of the ship or in charge of the case is the principal respondent. Others may be secondary respondents for specific roles they have played, and that role they must play with integrity and according to what they believe. If a patient is so sick that needed intubation, where the primary physician had written in the case note not to be intubated at all costs, this happens. Not as a treatment limitation, but because the primary physician has this prejudice against this procedure. Okay? The person on the job at that particular point of emergency is fully independent to take a decision in the eyes of law, I would say, because that is a life-saving procedure. If it comes to that, then a medical board anyway has to look at the correctness of that action, because a physician, whether or not primarily in charge or not, must act on his or her own volition and his or her own understanding. Law does not say that you've got to, like in the army, you have to follow the general. Does the law say that in medicine? I don't think so. The qualified physician acts under his own volition and autonomy. This is my understanding of the law. I don't know, Professor Nandimath, you must enlighten me on this. It's a very, very good question, but Jeet Kaur's question is
but any which way, sir, because you referred to me, your understanding is correct, is what I would like to, say. Even legally, because it is the principle of agency that comes into picture. When you're talking of principal and agent relationship, the principal binds the agent. And the agent is supposed, there are three very important duties an agent shall perform. This is what law says.
Yeah.
Number one, his first duty is to carry on the mandate that has been given to him without crossing the limitations set by the principal. So if principal says I should be doing X, I should be doing Y, I should not be doing Z, etc.
Yeah.
That is a mandate which I have to necessarily follow. That means there I would become a robot without having any intelligence in my head. That is the first thing. The second one is very interesting. They say you should do all that which is required to protect the interest of the principal, because you are not a robot. In fact, you are actually a person endowed with some kind of a discretion. And all the more, you are also a qualified doctor here.
yes.
And the third one, in case of emergency, you are to some extent, without violating the agency relationship, you can use your discretion. These are the three cardinal principles on which the principle of agency is built. So if you apply those principles of agency, Dr. Mani, 100% you are right. And we must, you also used a wonderful analogy. A military general or a commissioner of police ordering, the subordinate, and the doctor in hierarchy ordering another doctor, there has to be a difference. You can't put them in the same plane.
There is a difference.
The doctors should understand the bandwidth. So understanding law cannot be, actually reduced to some kind of mathematical protocols. This is what I keep saying whenever I get the opportunities. Don't try to reduce law into A plus B whole square formula. You need to understand the principles and apply those principles and on the toe take decisions and go ahead, keeping the interest of the patient in mind. So I just wanted to really say, Dr. Mani, you are 100% right. Law also provides rich literature for that.
Thank you, sir. Thank you.
Great. So now I see that we've kind of reached our last leg of the last 15 minutes of the session, and I think these questions didn't come in the questionnaire, but I felt that this is very pertinent to ask and very relevant. So this last section, I only want to discuss the very practical and procedural aspects of what a doctor should do when he or she finds themselves in a litigation or finds a complaint against them. So I'll start with, Professor Nandimath and then go to Dr. Mani. So, sir, what should one do when this happens? How do we go about finding a lawyer? The very, very practical aspects of what should a doctor do when he or she finds himself in such a situation?
See, I don't know if I am allowed. I would like to take one step back and say, Dr. Ujjvala, like today we are talking of multitasking, we are talking of skills, we are talking of, skilling has become a very important buzzword today, no? So if you apply it to doctor with respect to law, I always say some fundamentals of law, the doctors should also know. It has come to that stage today because of this real, danger of doctor being litigated on many counts. So the doctor is supposed to know, like, finance for non-finance, HR for non-HR. You talk about that, no, in a modern, world. So like every doctor, according to me, should know a bit of law, the fundamentals of law. Not that I am doing a pep talk of selling my services, but this is very important. But while understanding law, he should understand law from a different perspective. That perspective is using law as a tool of decision making rather than the tool of litigation. That is the most important thing. Thereby, he develops two, very important skills. The first skill is whether he is capable of resolving that sort of a legal impediment all by himself, or he requires a professional assistance. It's almost like if I'm a diabetic, I need to know a little bit about diabetes, is it not? Whether I would be able to resolve it all by myself, or I need to consult my physician or a doctor so that I can lead a better life. So that is a skill what a doctor requires today to practice. So without that skill, when you say immediately jump for a even minor kind of a thing, you jump and get into the clutches, like, from a pan to fire, you will jump and you are in for exploitation by lawyer friends of mine, right? Because you are, consulting them too prematurely. The second one is, I would say, okay, now I have diagnosed with that kind of a precondition. I have diagnosed, okay, I require a professional assistance now. Whether I should go to Professor Nandimath, I should go to Dr. Ujjvala. See, I wanted to tell you today there is, no database as such, accredited database as such, It is, I don't know, we have limited time, but let me venture out to say this. Today, if my wife sends me to the market, you get my point? She says, oh, you go to market and get me some rice. So in a supermarket, he has kept, 10 varieties of rice. One is, let us say, cheapest, one is the costliest. Except differentiating on cost, I cannot differentiate in quality because I don't have that skill at all. Yes or no? If my wife were to be accompanying me, she would make a difference. Oh, whether it is worth the cost, what they are quoting, etc. But I cannot make out because I don't have that skill. Either I take, all the rices I would equate with quality and go for the lowest cost or the highest cost or the cost which my pocket can afford. But I am not guaranteeing myself that I am buying what is called as the appropriate, what you call as a quality, right? So this is where the intermediary's job will become very important. What the intermediary does, he would put it into a bracket and brand it. It can be your agricultural produce. They brand it, saying that this is the A quality, B quality, C quality, so that I can buy the best affordable quality without worrying about the actual quality. Is it not, Dr. Ujjvala? So today, some leaders like Dr. Mani, or there has to be, even Cloudphysician, etc. They need to create that kind of a database which is required today, where they would say these are the people, certified people who can provide you good kind of a legal service. Because there is no database, it is like me buying, end up buying, rice in the market, right? Then the last thing I would say, when you have hired a lawyer. Let us presume you have hired a decently good lawyer. It is not like you take all your heap of papers or whatever you have, papers, documents, etc., dump it on his table along with a blank check and come back. Is not the good way. Because I always say, Dr. Mani probably may be able to recollect. When I and him, I said, no lawyer in this world has ever lost a single case. People will say, what are you saying, doctor? How can you say that? Then I say, it is not lawyer losing the case, it is his client losing the case. I don't have any stake there except ethical, kind of a moral ground I am taking. I don't have any stake either in your win or your loss. That is why you need to brief your lawyer properly.
Yes.
See, if you don't brief, you can't expect you to have an effective representation there. So these all are some of the prerequisites. More than procedure saying that A, B, C, and D, I would say keep this framework in your mind. And I once again say, I even attempted to write this framework saying that there has to be some intermediary, maybe somebody like National Law School or somebody like CII, somebody like Dr. Mani and Cloudphysician, or some kind of a credible body should intervene and start actually providing this kind of a service, saying that we are certifying these people to be good. And today what is happening, I will also add one more thing, although you are not directly intending to ask that, Dr. Ujjvala, courts don't decide by themselves. They rely upon experts. But many doctors know who are those experts who are creating opinion from the mouth of the doctors, right? Are they real, what you call as experts, or are they self-styled experts or pseudo experts? Because we don't have some kind of a, branding kind of a process where, okay, if you want expertise as far as this particular specialty, these are the people. There is nothing of that sort. But we end up blaming law, we end up blaming the system. But we are not contributing to develop a robust system today. Maybe I would think I would stop here. And if you have any very specific pointed questions, I would intervene. Otherwise, I would like to hear Dr. Mani.
Yes, Dr. Mani, before I come to you, at the end of listening to a lot of conversations like this, I often hear doctors say, oh my God, we have to be really scared. We have to be very careful when we practice medicine, which can oftentimes be a hindrance to their practice. What would you say to them, and how do you think they should handle before, like Professor Nandimath said, before any problem even arises? And of course, sometimes there may be a problem, and how do they handle that scenario?
I think we are at our best when we practice without fear or favor. Okay, we are supposed to treat everybody fairly, without discrimination, without prejudices, like a jurist would do, good jurist would do, and at the same time without fear. Okay, neither fear of the law nor of anybody. But you see, I don't know why we should fear the law. We fear the law only if we feel guilty about something. I think there are, we have to function responsibly. That is very clear. Okay, medical profession cannot afford not to be responsible at all. No profession can be, but I think maybe we have to fulfill this role of responsibility, more unerringly than in some others where the stakes are not so high. Okay. So the issue is, how do we function responsibly? It is an intersection of many things. Law is one element. Okay. See, law, medical standards, and ethics, it's a triangle. We have to triangulate every decision in this. There's no other way. So how can we be afraid of one or the other thing? We have to have an understanding. I think probably we're afraid because we don't have an understanding. Something we understand clearly and integrate in our lives, we won't be afraid of. Okay. There may be some element, as Professor Nandimath said, in certain specific situations. For example, in organ transplantation, you have a specific codified law, and you may be unaware of certain new developments. Okay, you may be unaware of certain clauses. Okay, that is it is incumbent on you to educate yourself on that if you're in the line of transplantation. Okay, that's a part of our obligation. If there's a new tax law, you have to know it. What are you being afraid of something? I think if we go to it in that spirit that we have to, our practice is incomplete or unsatisfactory or not as per standards, if we don't have these three elements. There is ethics. Ethics are the absolute foundation and ground. Okay, because anything that deals with human life or human beings in any way, for example, there's ethics in money transaction, there is ethics in business, there is ethics in banking, because they're dealing with people and their lives. So similarly, there's ethics. If you stray from that, you're liable for punishment, either by the medical bodies or, if it is severe enough, by law. And with that view, I think we have to monitor each other. In medicine, there is a very crucial part in medicine, which is called peer review. You cannot, just like you cannot be a sportsman without entering into competitions, you cannot be a physician without being peer reviewed, without allowing a peer to be critiqued, to be criticized, to be looked at, and we peer review other people. It's equal and opposite. So if somebody is straying from, very broadly from ethics, then you are supposed to raise that. If you're a responsible doctor, just as you're a responsible citizen, you've got to supposed to raise an alarm. For instance, if my colleague is found to be an addict, okay, he's injecting himself with some opioid, okay, and you happen to catch him. And now that person, he or she, can be a risk to the patients. You're supposed to report. Okay, so that is one. I think it's a written code. You're supposed to. So there are some medical code, but outside of the written medical codes also, there are certain ethical foundations which are understood. So law stems majorly from ethics. There may be some laws that come from the social understanding or from the religious culture of that place, like the abortion laws, okay, which you have no control over, which is not from the clearly medical understanding of that problem. Okay, that stems from some social intersections. They are also important because we live in the society and we function in the society. We've got to understand those things, culturally sensitive laws as well. It's a part of our obligation. And of course, the evidence-based medicine also behooves us to integrate the patient values, to integrate the story of the patient, the context of where you're treating. You can't just divest it of all that and just have a chemical or a physical intervention. So you've got to integrate all that. So I'll end there. I think this is, I just shared with you my sincere understanding of what I practice.
That was wonderful. I think there's no better end to this session with what you said, which is that we are at our best when we practice without fear or favor. I think that's a wonderful way to kind of put this entire session in context. And I think, thank you so much, Dr. Mani. It was wonderful listening to you. And thank you, Professor Nandimath. It was wonderful to have this conversation. And I think this is just the beginning of many more conversations. And it's also the beginning of, I think, the medical community coming together to create this framework, to create a system, to be part of the system and help build it. And I look forward to interacting with all of you a lot more in the future. Thank you so much. I hand it over to Dr. Rajesh if there's anything that he'd like to say.
Yeah, thank you, Ujjvala. Thank you. Thank you, Professor Nandimath. Thank you, Dr. Rajmani, sir. So, yeah, guys, so this is the end of the today's session. Please bring up your queries, questions. Let's solve the problem of misunderstanding or lack of knowledge in respect to medical law. So I thank you again for everyone joining. Thank you, sir.